Okay, this is the case of a 25-year-old male who presents to us with fever and fatigue, abdominal pain, and weight loss of 4 kilograms in the last 2 weeks. 1 day prior, nausea and non-bloody, non-bilious vomiting started. And that's the first aliquot.
Amazing. Well, I will sort of give everybody a few seconds to process this aliquot that Sammy just gave us. And we'll share that I think, this is a initial aliquot that has a lot of information, but also not necessarily a ton of localizing features. I think if we were to look at each of these chief concerns or I should say each of these presenting symptoms in isolation, we would see that there is actually a huge challenge to sort of make some progress towards localizing what both the etiology and the site of the pathology is, right? We oftentimes can think about how fever, while it can be a system that suggests underlying systemic inflammation, really doesn't help us localize. We oftentimes look for organ-based manifestations to help localize. And in this case, we have abdominal pain, weight loss, and some, oops, my light went off in here, give me 1 second. In this case, we have some abdominal pain and nausea and vomiting, which I think may push us to say, oh, the center of gravity of this case is going to focus on the abdomen. But I will say in practice, all kinds of different illnesses that either start in the abdomen or have nothing to do with the abdomen can cause these symptoms, right? If somebody has a systemic viral infection like the flu, they can get some abdominal pain and even some episodes of emesis just from the systemic illness, right? Even things like DKA or a metabolic acidosis, right? Something that isn't necessarily related to underlying GI pathology can also cause things like abdominal pain and emesis. And so I think really all we can say at this point in time is that this is somebody who has a syndrome of systemic inflammation, and that systemic inflammation could be manifesting with nausea and emesis, or the nausea and emesis could be something that's localizing us to the GI tract, but it's hard to necessarily know where we are right now. I see a lot of great thoughts coming in the chat, and I'm just going to ask Brandon to unmute and share a little bit more about what you just mentioned if you're in a spot to do so. Maybe if Brandon, if you're not able to unmute, I will come over to you, Angelita, to share a little bit as well. Oh, no worries, Brandon. I think Angelita is on a night shift as well, so maybe my third time will be a charm here. Anise, are you able to unmute and share a little bit more about what you're thinking in terms of the hepatobiliary system? That's all right. Well, I will just say, I think there's sort of two potential paths that we have to go down here. One is that the abdominal pain and emesis is signal, and that we should focus our cognitive efforts in looking in the intra-abdominal space, right? And that this systemic inflammation is related to something happening in the abdomen. So that's one track to go down. The other track to go down is going to be actually that this is a purely systemic illness that happens to be leading to the development of symptoms that include abdominal pain and emesis. I think another thing that is particularly interesting here is to sort of think about the tempo of the illness, which Sammy has not yet given us that. It sounds like there's been a 4-kilogram weight loss over the last 2 weeks, which maybe pushes us into a more indolent subacute process. And it's also possible that he only noticed the weight loss over the last 2 weeks, but that there could be something that's been happening for a much, much longer period of time. I will say whenever I see a young person who has a non-acute systemic inflammatory disease, there's two things that I wonder. One is, what is his underlying immune status? And the other one is, what are his potential exposures that could be happening? Because if we think about disease processes that can cause syndromes of systemic inflammation, we're going to prioritize infection and then also think about malignancies and underlying autoimmune diseases, as well as endocrinopathies. The question then is that, how does the time course shift us? The longer someone's systemic inflammation lasts, the more we will move away from acute pyogenic bacterial infections or acute viral infections and think about indolent infections as well as non-infectious causes of systemic inflammation. And so I think in this case, the fact that it's 2 weeks does make me start to entertain potentially more indolent infections, which could be related to exposures, for example, environmental exposures related to mycobacteria or endemic fungal infections, and then also exposures that may put him at risk for immunocompromising conditions like HIV. So if he is somebody who engages in sexual activity or other forms, for example, injection drug use that may expose him to acquiring HIV, that will radically shift our thinking here as we think about the non-pyogenic, non-viral infection DDX. But I think at this point in time, where most of our effort is going to go to is saying, how do we actually define the syndrome a little bit better, both in terms of time, but also where in the body this may be happening. Because once we're able to do that, localize the syndrome or better define the syndrome and understand the tempo, we'll be able to make a lot more progress in terms of thinking about if it is an infection, what kind of infection is it? And if it is a malignancy or an autoimmune disease, whether we're going to focus on something like a connective tissue disease, a vasculitis, or something like a lymphoproliferative disorder. So I feel like that sort of is where my brain is at right now, and knowing Sammy, there's going to be many more twists and turns along the way.
Okay, great discussion. So the pain is in the upper abdomen, so he can't really localize it to the epigastrium or the right or the left upper quadrant, but he says the upper abdomen does hurt, but it doesn't radiate to the back or to the shoulders. The pain is 4 out of 10 in intensity and is constant. He denies any other pain, dyspnea, urine or stool changes, no hematochezia or melena. His past medical history is basically unremarkable except for an inguinal hernia operation on the left side 3 years ago. For medications, he took ibuprofen 4 times 400 milligrams a day since 1 week. He does not smoke, does not drink, and also denies use of illicit substances. He has a girlfriend with which he's sexually active, but they use condoms. He had no sick contact, and family history is non-contributory. Do you want more information, or?
Yeah, I think it would be great to at least have an exam at this point. Otherwise, I'm just going to be pontificating about really interesting information, and I want to spare the group any further monologues.
Okay, so for his physical examination, he was alert and oriented ×3, but appeared fatigued. For his vitals, his temperature was 36 degrees Celsius. Heart rate was 96 per minute. Blood pressure was 125/75. And it dropped to 105/70 when he stood up. And his respiratory rate was 16 per minute. For his hint exam was basically unremarkable. The tongue was dry, otherwise it was unremarkable. Anecteric sclera, no pharyngeal erythema, no cervical lymphadenopathy. Cardiovascular exam, he was also basically unremarkable. No murmurs, rubs, or gallops. Lungs were cleared to auscultation bilaterally. Abdomen was soft, non-distended. no rigidity, but he had strong epigastric pain on palpation. Epigastric pain on palpation, yeah. And milts and liver were palpated 2 centimeters under the costal margins. And his skin, there were no rashes and no icterus. If you have any other questions, you can ask me on the physical examination.
All right. Thanks so much, Sammy. There are some awesome questions coming through the chat here. I actually want to first come to you, Elisa, to share a little bit more. I think you asked this really astute question about understanding this gentleman's travel history. And I'm curious where how you're linking the role of his travel history with this presenting symptoms. Do you mind sharing a little bit more? I think it's a great question.
Yeah, sure. Well, I just thought knowing his travel history might give some clues of any potential infectious causes, especially if he was, for example, from South America, where he may have been exposed to H. pylori or certain other infections that could tie in with the rest of his syndrome, this like epigastric abdominal pain. And given that the infection has been about 2 weeks of his symptoms, he's kind of in the borderline of an acute versus a more subacute presentation at this point. So I think infectious causes of his symptoms are pretty high up in the differential at this point. And so kind of having a better idea of which types of infections to consider based on his travel history.
Awesome. Thank you. So I think those are absolutely brilliant points. Thank you so much for sharing those with us. I love how you're using the tempo of the patient's illness to think about the background and the role of the travel history here. And then I see Hans brought up a couple really good points in terms of the vital sign abnormalities, as well as his interpretation of the abdominal exam. Hans, do you mind sharing a little bit more?
Yes, when I looked at ibuprofen, but of course there are many more twists and turns. This is too easy and a suggestion. But upper gastrointestinal or epigastric pain, I was right away thinking about anything wrong with his stomach. So with his, maybe he has an ulcer, H. pylori would be a possibility, or something that he ingested from a travel. We don't have the travel in history that might cause him any problems with his stomach.
Amazing.
And of course, I was also thinking about adhesions, but this is quite with care, because I'm not sure about that one.
I love it, though. Hans, I think that that's a fantastic point to be thinking about. Okay, this is somebody who has had surgery before, and the presence of a prior surgical operation that sounds like may have at least involved the inguinal region, and maybe there was some intra-abdominal approach as well, right? We have to sort of frame them as somebody who may be at risk for post-surgical complications, of which one of them is bowel obstructions from adhesions, right? It's going to be one of the sort of top 3 differentials as a cause of an SBO. And someone who has emesis and vomiting and abdominal pain, we have to always think about obstruction in our sort of list of the acute life-threatening causes of abdominal pain. I want to also elevate Angelita's question about sort of getting a better understanding of why this gentleman started to take ibuprofen, right? Was there something else that led to the addition of ibuprofen, which could be exacerbating the abdominal pain, particularly if he has underlying peptic ulcer disease, or was the ibuprofen used solely for the abdominal pain alone? That can become helpful because if there's another localizing site, like if there's joint pain plus systemic inflammation, that may change the way we're thinking about the abdominal pain and give us a new place to focus our cognitive efforts as we reason through the case. And so I think that that's a really, really nice thread to go to. And I just want to say thank you for asking that, Angelita. And then I think everybody, there's a lot of other really great points here. I think from Anis to Ravi to Vivek about thinking about, what are we going to do about interpreting the abdominal exam? I will say that like looking at this abdominal exam right now, if I were to be seeing this gentleman in clinic or in the urgent care setting, I think it would be challenging to necessarily know what the best course of action is, right? Somebody who's been having nausea and episodes of vomiting, it's totally plausible that their stomach is going to be a little bit irritated and their distal esophagus is going to be irritated. And that could give them some tenderness on exam, right? So there's one world in which you say, oh, this abdominal exam is solely related to the fact that this gentleman was having nausea and vomiting. And if we weren't on VMR, right, knowing the way that these cases tend to unfold, we might feel comfortable sort of saying, you know what, I think that you're having some gastritis or some gastroenteritis and that should get better. But the two pieces of information that I think make me feel like that is a plan that potentially has some risk to it are, one, the tempo of the illness, and two, what sounds like the degree of pain as well as the presence of the palpable liver edge. And I think there are some scenarios in which we can buy ourselves out of cross-sectional imaging for somebody who's coming in with acute abdominal pain. One of those is going to be DKA, right? Because the DKA gives us a very plausible explanation for why the person is having abdominal pain. The other one is going to be acute pancreatitis, right? If we find that lipase is elevated and they have abdominal pain compatible with pancreatitis, we don't necessarily need to get cross-sectional imaging in all of those patients. And the third one is going to be if we have a very plausible explanation of gastroenteritis, right? Somebody has acute nausea and vomiting, as well as plus or minus the presence or absence of diarrhea, right? A lot of those patients may come into the clinic, into the urgent care setting, or into the ER. And if there's nothing super concerning on labs, right, and we can feel like, oh, this seems all very compatible with a classic case of gastroenteritis, we oftentimes won't need to get cross-sectional imaging of those individuals. But none of those illness scripts are necessarily fitting perfectly with those three diagnoses yet, right? We don't have the labs yet, so those will be very, very helpful. But I think two weeks of weight loss and a systemic illness doesn't fit well with gastroenteritis, which is usually a disease that's going to last for days. We don't necessarily have a clear understanding of this gentleman's acute pancreatitis, which I would usually expect to progress over days rather than weeks. And then finally, right, we may get a clear answer on the DKA soon. But I offer those examples as saying that usually when someone comes into the ER with acute abdominal symptoms, we have to sort of buy ourselves out of cross-sectional imaging in those cases, because there's so many things that can be brewing in the abdomen that may not present overtly, but are still severe underlying disease. And so I feel like this is a case where we're going to have to convince ourselves out of getting the CT scan, because there's been weeks of symptoms, there's a signature of systemic underlying inflammation, there's weight loss, and then we also see that there's some pretty impressive palpation on exam and some signs that maybe there's more than just the epigastric area that's involved with the liver. And so I think what we're going to be looking for on labs here is to say, is there information that can support cross-sectional imaging, or is there information that can buy us out of it, which would be something like rip-roaring DKA as a new diagnosis, or rip-roaring pancreatitis, right? Because then we're going to sort of manage the pancreatitis and see how the abdominal pain evolves. And so I feel like at this case, right, the momentum of the gentleman's symptoms, the illness course is all going towards cross-sectional imaging, but we're going to have to see where things unfold. I think Ravi brought up a great point in the chat as well about the possibility of an acute viral hepatitis, which could have non-specific symptoms, but also give us this potentially enlarged liver that we're feeling on exam here. And so I think we're really going to use the signature of the labs to help us guide not only where we go next, but also what organs we start to localize. Because at this point, we're still sort of saying it's something happening in the abdomen, but we're not necessarily able to move closer to one of those organ-based pathologies quite yet. So I'm super curious to see what we end up finding on labs here, Sammy.
Okay, yeah, great discussion. Just to give you more information, he had no health-related behaviors and no allergies. And on the history of the presenting illness, no arthralgias. He took the ibuprofen for the abdominal pain. So proceeding to the labs, his white count was 11,500 with 53% neutrophils, 34% lymphocytes, and 10% monocytes. His hemoglobin was 16.7. His hematocrit was 48.8%. His MCV was 85.3. And his platelet count was 257,000. For his BMP, his sodium was 132, potassium 3.3. BUN was 33.6. His creatinine was 0.83. His glucose was normal with 86. For his LFTs, ALT was 313. AST was 192. Alkaline phosphatase was 57. GGT 35. And bilirubin 0.4. And GGT was was 35. Albumin was 1.5, and total protein was 4.2. And that's it.
Quick question. What was the sodium again?
132.
Okay, and you said the GGT was 35. Okay.
Yes.
All right. All right. Sammy, do you happen to have a UA as well right now, just in terms of time management?
I can give you the UA. I don't have a UA. I only have a 24-hour urine, which was 0.14. And otherwise the UA was normal.
Okay, that sounds good. So it sounds like not heavy proteinuria.
No heavy proteinuria.
All right. Well, this is very, very interesting here. So it seems like the features that we have here is sort of like maybe a borderline high white count. We have a hemoglobin of 16, but as Ravi is brilliantly pointing out in the chat, we have a good reason to suspect that this gentleman is dehydrated and hypovolemic based off of the orthostatic vital signs. And so maybe that hemoglobin will probably normalize with some volume resuscitation here. But then I think the things that we sort of have to reconcile with is a acute hepatocellular injury, and then this very, very low albumin level. And so I think the question is why is this gentleman losing out, or why does this gentleman have a very, very low albumin? And if we can think about, there's really 3 ways in which we can have underlying, or I should say 4 ways in which we can have a very, very low albumin. One of them is that there is an illness that leads to systemic inflammation. Albumin is a negative acute phase reactant. If we think about other acute phase reactants like ferritin or white blood cells, they will go up often in the setting of inflammation, whereas albumin will usually go down in the setting of inflammation. And so that's one hypothesis, that whatever systemic inflammatory illness this gentleman has, it's driving his albumin down. But we also have to be open to the possibility of there being difficulties producing albumin, which we have one cause for, which is going to be in terms of the liver taking a hit now. So the liver could be having difficulty making albumin. And then also he could be losing albumin from somewhere in the body, which the 2 places that we oftentimes lose albumin and protein is going to be in the urine in the setting of nephrotic syndrome, or in the GI tract in the setting of something called a protein losing enteropathy or another malabsorptive progress. And so what we're going to have to ask ourselves is 1, what is the cause of this gentleman's acute hepatocellular injury? And 2, is the liver injury what's driving the albumin down, or is there potentially another process happening here? I will say Ravi's hypothesis about acute viral hepatitis is is continuing to gain more and more momentum here. If we think about the things that can cause acute hepatocellular injury, that list is exhaustive. But it can really focus, I think, on basically 3 underlying processes. One is that you can have a acute hepatocellular injury from viral infections that involve the liver. We can break those down into the professional viral hepatitis, right? The ones that have hepatitis in the name: hepatitis A, hepatitis B, and hepatitis C. Usually hepatitis A is going to be the most acute of those. Then we have what I like to call the non-professional viral hepatitis, which is the ones that don't necessarily have hepatitis in the name, but they still involve the liver. And those are going to be things like EBV, CMV, and the rare but devastating diagnosis of HSV hepatitis, which can cause anything from acute liver injury to fulminant acute liver failure. So I think we're going to be looking for, right, the acute viral hepatitis, both the professional or the non-professional ones. Then we have to ask ourselves, are there non-infectious causes of underlying hepatocellular injury? And of course, the answer to that is yes. That can range anything from autoimmune diseases like autoimmune hepatitis, but also other connective tissue diseases that may just involve or bring the liver on the hook. For example, dermatomyositis can fall under that list. Oftentimes it's going to come with some degree of hepatocellular injury. There's a long list of drugs that can also do it, but when somebody has liver enzymes that are sort of mildly elevated like this, the list expands even more and more. And oftentimes we'll have to just see how the liver enzymes evolve to decide how much further we want to work this up. Other things that can do it are going to be things that we can usually pick up on ultrasound. So for example, if somebody has a gallstone that ends up clogging up the biliary system, but then ultimately passes, you can leave a trace of a hepatocellular injury there. So certainly gallstone disease or biliary tract disease can also cause a low level elevation. And we might not see the elevated bili and alk phos if things have already passed. And so if this was a stone that was there and has now passed, we can see a hepatocellular pattern like this. And then lastly, the thing that we worry about is going to be underlying vascular pathologies, particularly like Budd-Chiari, but those will usually have LFTs in the thousands rather than the hundreds like this. But I think where we're going to go here is sort of make sure that there haven't been any other supplements he's been taking that could cause hepatocellular injury. We're going to test for the viral hepatitis and probably get imaging of the liver, either via ultrasound or a CT scan, to see if we see a signature of gallstone disease as well. And that's probably where we're going to take, at least that's probably where I would take the first pass workup here. And then if all that comes negative, we'll move into sort of phase 2 of working this up and ask ourselves, are there other less common diseases that could be involving the liver? But exploring those right now, I think would probably be not authentic to the reasoning process that would be happening in real time.
All right. Then for the next set of data, his INR was 1.1, his amylase 64, LDH was 1091, CK was 69, CRP 20, and ESR was 22. He was asked if he had eaten less in the last 2 weeks, and he said that he ate about 1,500 calories a day. For imaging, he received CT of the abdomen, which revealed splenomegaly of 15 centimeters, hepatomegaly with 4 small hypodense lesions, which were thought to be hemangiomas, moderate ascites, and small pleural effusions. The CT abdomen also showed increased gastric folds or hypertrophied gastric folds. Tissue transglutaminase antibodies were negative, and IgA was normal. For his viral serologies, hepatitis A virus IgG, IgM, anti-hepatitis B surface antigen, anti-hepatitis core antigen, and anti-hepatitis C virus antibody, and hepatitis C virus PCR was negative. EBV viral capsid antigen IgM was negative, IgG was positive. Epstein-Barr virus nuclear antigen IgG was positive. Cmv IgM was elevated, and Cmv IgG was 6 and is considered normal about 7, more than 7. So IgM was positive for CMV and IgG was negative. And the other viral serologies were negative. And HIV was negative.
Thanks so much, Sammy. I just want to make sure that we have the viral titers correct up on the board. So it sounds like Hep B, Hep C were negative, but the only positive was the CMV IgM.
Yes, totally.
Okay. And then did you happen to have PCRs for either of those, or are those coming?
The PCRs were negative for EBV and HIV, and PCR was also elevated for CMV.
Interesting. All right.
So he had CMV viremia.
Cool. So this is going to be a really, really fun piece to sift through now at this point, because we have the findings of CMV viremia. We have these super interesting CT scan findings, some of which are localizing or at least problematic in some way, but also some of them that maybe aren't necessarily going to be fully explained by what we have here on our viral titer. So I think the place to start with is actually probably going to be, let's talk through what we have on the imaging here. So we see splenomegaly, we see these liver lesions with hemangiomas, and then we see moderate ascites, small pleural effusions, and hypertrophic gastric folds. So I think when we think about the finding of splenomegaly, I'm just going to pull something up here. Harry, if you don't mind if I take over the screen for just a second.
Yeah.
Is everyone able to see this okay here? You all see our splenomegaly schema? So when we think about splenomegaly, right, the question is going to be, what is making the spleen swollen? Is this water, or is this something else? And the something else can be one of three things: red cells, white cells, or small molecules. Oftentimes, particularly in somebody who has a systemic inflammatory syndrome, we're going to start thinking about the white blood cells first. But it's worth noting that things like amyloid and then rarely lysosomal storage diseases can cause the spleen to get large. And then if somebody has underlying infections or underlying genetic hematologic abnormalities like a thalassemia or hereditary spherocytosis, we can get splenomegaly from red blood cells in the setting of chronic ongoing hemolysis. But if you see here, our biggest DDX is going to sort of focus on the finding of white blood cells that are making the spleen enlarge. And I think we have a number of reasons to suspect that here. One, we have a syndrome of systemic inflammation. Two, we know we have viral particles within the bloodstream. And then three is that we have some signature of underlying systemic malignancy, with the LDH being very, very high. And so if we ask ourselves, well, then what are the things that could cause this? We can have infections, which can include things like EBV, CMV, and HIV, right? So the CMV viremia could certainly explain the splenomegaly here. But then there's also things like granulomatous diseases as well as tick-borne diseases that can do it. There's some myeloproliferative disorders that can do it, which if we didn't have Ravi's help making us less concerned about the hemoglobin, we might think about a myeloproliferative disorder in this person who has a hemoglobin in the high 16s. But really, for somebody who's 25 years old, where we have the explanation that they're dehydrated, a myeloproliferative disorder seems unlikely here, right? Certain drugs can do it if there's a systemic syndrome like DIHS. And then you can also have certain autoimmune diseases, but then most importantly, in a young gentleman with B symptoms like this, thinking about lymphoma, particularly with the LDH that's very high. So then the question is, well, what do we make of the other findings on the CT scan, right? The moderate ascites and the small pleural effusions are probably related to the underlying hypoalbuminemia, or at least that's how I'm putting them together at this point in time. So really the question then becomes, well, what could be causing these hypertrophied gastric folds? And I think that there's a couple of things that can come to mind here, right? I saw that, I think it was Aziz who mentioned in the chat that the hypertrophied gastric folds could be related to something like Menetrier's disease, which is a great point. Aziz, I love that you brought that up, because Menetrier's disease is also known as a protein-losing gastropathy. So that can certainly put all of these things in place, right? The gastric folds could be from the protein-losing gastropathy. The hypoalbuminemia could be from a protein-losing gastropathy. But what I have a tough time reconciling in that case is where the splenomegaly fits in. However, the CMV viremia could be on the hook here. So there's one hypothesis that we go down, which we say that this gentleman has a protein-losing gastropathy from Menetrier's disease that led to underlying immunocompromise, because in addition to losing things like albumin, we can also lose immunoglobulins in that scenario, and that can lead to the development of CMV viremia, which many of us face, but most of our immune systems are able to contain. So that's one potential route. But the other thing is to say, well, what else can cause hypertrophied gastric folds? And what I want you to think about is going to be infiltrative malignancies as the other DDX that is super important to rule out in that case. And those things can include, infiltrative malignancies can include things like infiltrative gastric adenocarcinoma, oftentimes called Linitis plastica, or you could see like signet ring adenocarcinomas. And those can cause basically gastric cancer without mass-like lesions, but you'll just see these sort of hypertrophied gastric folds. The other one that can cause an infiltrative malignancy is going to be something like lymphoma, which we've said we already have multiple possible hypotheses for in terms of the LDH being high, the B symptoms, as well as the splenomegaly. And it's also worth noting that sometimes lymphoma can lead to the reactivation of a previously controlled viral infection, like EBV most commonly, but also CMV as well. So lymphoma is certainly plausible given this whole picture here, because the lymphoma could also lead to the gastric malabsorption. One other thing to think about when you see these hypertrophied gastric folds is Zollinger Ellison syndrome, which can come from a gastronoma. So there is some sort of neuroendocrine tumor somewhere in the abdomen that's leading to high amounts of gastrin secretion. That gastrin can then lead to high acid production, and that high acid production can cause some of the symptoms that he was experiencing, like epigastric abdominal pain. One thing that I have a hard time necessarily bringing into place is the Cmv Viremia, but certainly if there is an underlying tumor, we could think about there being underlying immunocompromise. So then if we zoom out, the question is like, well, what do we have the most likely syndrome for, and how do we prioritize it? And I would say I would probably prioritize it based on what's the most morbid. So prioritizing cancer first, and then thinking about Menetrier's disease after that, right? Because we're going to want to make sure that we don't miss lymphoma or an underlying neuroendocrine tumor. The good news is that we don't necessarily have to be right now. We just have to know what the best next step is, which I suspect is going to involve tissue sampling via potentially endoscopic approach. If we can get an EGD and look at the mucosal lining of the stomach, we might see characteristic features of one of those diseases. We might see multiple gastric ulcers that suggest high acid secretion, which may move something like Zollinger-Ellison syndrome higher. We may see that actually it looks like there's sort of infiltrative cancer throughout the GI tract and particularly throughout the stomach, which may put lymphoma or invasive gastric adenocarcinoma a little bit higher. We might also see classic findings of Menetrier's disease, where just lots and lots of folds with negative biopsies, and we may settle on that diagnosis as well. So I think I have a hard time necessarily saying what's the most likely here, but those are the things that I would be worried about. And from a management perspective, right, we're going to focus on a tissue diagnosis, and both in terms of ease of access and the likelihood that the pathology is going to be in that space, the stomach seems like a great place to go next. Sammy, I'm very curious to hear where this goes. So I'm going to say, just go ahead and take us home with the final diagnosis here, and then we can reflect on the case together.
Okay, yeah, great discussion. Also, the chat is amazing. So for the last bit of information, so a gastroscopy was performed, which revealed moderate esophagitis, prominent gastric folds with erosive gastritis, and the duodenum was actually unremarkable. Biopsies were taken and revealed viral inclusion bodies in the gastric folds with foveolar hypoplasia, glandular cystic dilatation, and immunohistochemistry was positive for CMV. So the final diagnosis was thought to be Menetrier's disease with primary CMV infection, which is actually a thing, and I also didn't know that. And the CMV infection also explained his whole systemic symptoms and the subacute time course. And the low albumin was explained by the protein-losing enteropathy caused by the hypoplastic gastric folds, which led to the protein loss. Yeah, I found this case really interesting. The patient also, he received omeprazole and protein-rich foods, and basically recovered within 1 month, and gastroscopy 2 months later were unremarkable. Yeah, so this was the case.
Amazing case, Sammy. So it sounds like it was CMV infection leading to Menetrier's disease, leading to protein-losing gastropathy.
Yes.
Incredible, incredible case. I just want to say that chat, you all were on the scent of this from the get-go. I think that is just so awesome. And it's a huge learning point for me. I feel like it's plausible to see how a protein-losing gastropathy and CMV infection can be linked. But I honestly thought that it was going to go in the other direction, that the Menetrier's disease would lead to reactivation of this infection. And it sounds like actually the CMV infection probably set up the Menetrier's disease. So that's a very helpful change in terms of the ultimately causal path here. Sammy, I would love to hear any sort of final reflections from you in terms of things that you learned from this case before turning it over to Deborah for the teaching points. But this was just so much fun, and I had such a blast getting to think through this with everybody.
Yeah, I also didn't know this before, but CMV can cause Menetrier's disease, is one of the most common causes. The duration is also shorter than with idiopathic Menetrier's disease, which also occurs at older ages. And yeah, also whenever we see hypoalbuminemia, also think about GI losses, which in my opinion is highly under thought of. And yeah, this was an amazing discussion. Thank you all so much.
Thanks.
I don't know if you have any thoughts.
Thank you. Yeah, I think it's a great, right? Oftentimes when we see a low albumin, we're like, oh, we're going to blame the liver or we're going to blame the kidneys, but the GI tract can sometimes be a forgotten source. And so I'm glad we got to at least early on invoke the possibility of a protein losing enteropathy, and then to ultimately have that hypothesis confirmed. Because I feel like sometimes I think about those rare causes, and when they never play out, I think about them less. And so you are going to help me now continue to think about protein losing enteropathies in the future to make sure that we don't ultimately miss this. I just want to give a huge thank you to everybody who participated in the chat again. Another really, really warm welcome to Renzo, Alessandra, and Elisa today. Thank you so much for your contributions. And I'm going to kick it over to Deborah to take us home with the teaching points. And then also before that, Harry, thank you so much for the awesome scribing. We appreciate you so much today. And then now I will kick it over to Deborah to take us home with the teaching points.
Yeah, Harry, you did great for the first time, and absolutely, we hope we'll get back here soon. Thank you for the case, it was really great. And for the teaching points, thinking about the abdominal pain, nausea, and vomiting, all kind of the disease can start with that, even that it's not in the GI tract, can be like in a systemic inflammation. And thinking about the non-acute causes can be something that it's about the immune status or an exposure to an infection. And after that, we can think about autoimmune or malignancy. And in this case, the differential diagnosis was surgery, infections, obstruction, pancreatitis, and gastroenteritis. And the low albumin, we can think about that can be a systemic inflammation that different from the other inflammation marks go down, can be a difficult in the projection in the liver, or can be a loss in the urine or the gastric intentional. And the disease involving the liver, we think about the infection, autoimmune, dermomyositis. Drugs can think about something in the gallstone or in the biliary tract or some vascular. And about this splenomegaly, the common cause can be from the water, but as like in a portal hypertension. And other cause can be from the red blood cells, like infection or genetic, or white blood cells with infection drug, something myeloproliferate, malignancy, and autoimmune, and then the last can be from moleculars. So thank you, everyone. I hope to see everyone tomorrow.
Thank you, everybody. Have a great day. We'll see you next time.